All right. Good morning, everybody, and thank you so much for being here. Today we have two talks, one on point of care ultrasound by Dr. Shah and one on blast and ballistic injuries by Dr. Stewart. So thank you so much for being here. Also, thank you to Dr. Hoffman, Dr. Maddox, and I see Dr. Hughes here as well. We appreciate you all being here and giving your advice and support. So Dr. Host, thank you as always for hosting us, and thank you to all of your surgeons and trainees for being willing to be here even in such difficult circumstances and with such limited electricity and internet, particularly at the moment. So thank you very much. And we'll get started if Dr. Host, if you'd like to say a few words, and then we can start with Dr. Stewart.
Thanks. And Dr. Davis for an introduction. And so I would like to thank all of the Dr. Mattis and Dr. Andrew and as well as Dr. Davis for your for wonderful organization. And also I would like to thank all of our attendees to join our session today. And so if you have any question, you can put in the question you go on the screen, and we can Dr. Davis can go in there with that. And our eminent speaker is Dr. Barclay Stewart, who is also a board certified trauma and critical surgeon, and as well as the assistant professor of the surgery in the division of trauma, advanced and critical surgery at the University of Washington School of Medicine. He obtained his medical degree from University of South Carolina and graduate degree from the London School of Tropical Medicine, as well as Stanford University. He completed residency in general surgery and fellowship in trauma, advanced and critical surgery at the University of Washington. He has a diverse research pursuit that include model resuscitation for burn injury and long-term outcome of the patient with the burn. He recently joined the editorial board of the World Journal of Surgery. Our next speaker is the Subxiphoid View, who is an associate professor of emergency medicine at the University of Washington School of Medicine, and will also work clinically at the Harborview Medical Center in Seattle. She's also a director of the emergency medicine, and we will have fellowship within the division of emergency medicine at the University of Washington, and also an internationally known expert in the field of final care ultrasound in the limited resource setting. She also a chair of past chair of the American College of Emergency Physicians, the National Ultrasound Subcommittee, and the American Institute of the Ultrasound in Medicine. She also enjoyed providing emergency care to patients and working closely with educate team to provide patients with holistic approach to their care. Now I would like to thank our discussant, Dr. and trauma liaison, Dr. Mattis into this session, and also who is Mattis is also the most recognized surgeon, and he's also synchronous with the trauma surgery and other our various trauma dashboard and also the subcenter dashboard of surgery and the top 9. And she had all lectures over the entire country with a constant number of time over the past 50 years. Together with Dr. Mattis, Dr. Michael Hoffman is also a discussant and who earned his medical degree from University of Pittsburgh and also completed his training in general surgery at the same university, along with the research in critical illness or trauma, before completing additional training in surgical and critical surgery. He joined the Michael E. Tabaki Department of Surgery at the Baylor College of Medicine, and his research include the debility of the trauma and critical illness, and recently received Faculty Award for Excellence in Patient Care. And without further ado, I would like to hand over to Dr. Davis from Bento Hospital, who is also one of the top trauma surgeons in Texas, and who will serve as the moderator of today's discussion. Dr. Davis, thanks for coming back to us again, and over to you.
Thank you so much, Dr. Host. Dr. Stewart, I don't know if you have some images to share, but you can share your screen if you'd like to do that. And just to warn you, I already have quite a series of questions on blast injuries for you. So it's obvious there's a great deal of interest in this. I'll be collecting questions by the chat and consolidate them. So both of you will speak, and then at the end, we'll just go through all of the questions from both of your talks, okay? All right, thank you very much.
That was great. Thanks, Dr. Davis and Dr. Host for the introduction. And I realize there are lots of experts on the call and certainly people with lived experience caring for these injuries. So I welcome any interruptions and questions as they come up, and you can feel free to field those, Rachel, as we go. So I think one of the most important things about blast injuries is how the physics really informs the care that we have to provide. So we'll talk about the physics of blast injury in a bit of detail, and then that'll inform the wounding patterns and the care that we provide for blast injuries. And we'll detail a few individual and system-based practices that we might be able to implement that might maximize care and recovery of people with blast injuries. So some basic blast injury principles in the order of physics. So there's high order and low order explosives, and they differ in a major way. The first is that high order explosives create an overpressure wave, and that is expanding gases that arise from a solid or liquid medium that travel at extreme speeds up to 1 kilometer per second. Compare that with low order explosives, which is effectively a burning of a fuel and an oxidizer source like gunpowder or even a pipe bomb. And the speed at which that gas travels out from the blast is very slow in comparison to 1 meter per second. That said, certainly the shrapnel and fragments from pipe bombs and such can still create significant injuries and are often conceptualized quite similarly. However, the index of suspicion and the aggression in which we have to identify and look for other injuries is much higher with high order explosives. So this is just an image that helps understand the extreme nature of the blast wave, since it can be well visualized here. And it leads to what we know as an idealized blast wave dynamic or a blast wave curve. And once there's a detonation of an explosion, there's a rapid rise in the pressure that is experienced by whoever or whatever is in the way of the blast wave. There's a positive pressure phase that is dependent on a few things. One of the most major is obviously what is the content of the explosion and the amount of the explosive material. Additionally, how close one is to the explosion. And then within enclosed spaces, like buses or tunnels or buildings and such, the blast wave can actually bounce off of hard structures and cause a prolonged positive pressure or impulse phase that can lead to more significant injury. We'll talk about the negative pressure phase here in a second. So this is a diagram on the left, just a conceptual diagram of a house and a tree with the pressure curve over here to the side. As you can see, we definitely get the overpressure wave and the impulse positive pressure phase, but there's a vacuum that's created as that gas moves away from the explosive ordnance. And then there's a blast wind that returns with quite a high negative pressure as well. And both of those things can cause particularly tertiary blast injury with a negative pressure wave or blast wind. So the categories of blast injuries are important to consider only in that we look for these types of injuries when we're assessing patients who've been injured by a blast. So primary injuries are those that are the direct effects of the blast wave. We'll talk specifically about blast lung and TM rupture and a couple of other primary blast injuries. Secondary blast injuries are the impacts of fragments. These are penetrating injuries. Well, oftentimes explosive devices create fragments, whether they're intentional or picked up by the environment and impaled into individuals. And these travel at speeds markedly faster than bullets. Therefore, the amount of injury that they can cause internally is quite significant, despite not being very impressive externally. Tertiary blast injuries are from the body being displaced from its position due to the blast wave or the blast wind, or collapse of a structure related to the blast injury, for instance. And they injuries commonly associated with tertiary blast injury include fractures and crush injuries. Quaternary injuries are from heat and radiological contamination, for instance. Classically, burns and inhalation injury are what we think of most. And quaternary causes of injury are other contamination to include bacteria and debris, and certainly the host response to injury, which is enormous in these multidimensional, multi-system injuries with significant soft tissue components and multiple cavity injuries. This can lead to metabolic derangements, very severe immune and immune dysregulation and inflammation, and certainly infection in the longer terms. So primary blast injuries are due to compression, expansion of gas or fluid-filled spaces, particularly at those interfaces because of the shear forces of the blast wave. As the blast waves move through fluid markedly more effectively than air, any cavity or tissue where fluid and air are adjacent to one another, there's significant shear forces. In the lungs, the pulmonary shear, hemorrhage, and edema are quite common and lead to blast lung, and we'll talk about that in a touch more detail. Auditory injuries like tympanic membrane ruptures, abdominal injuries, particularly hollow viscous perforation, and fractures of solid organ injury and mesenteric injuries, particularly with the tertiary injuries and blast after blast, where there's acceleration or deceleration of the individual who's displaced. Neurological injuries, there's a specific entity of blast traumatic brain injury. There's gas emboli that can form from blast lung that can ultimately cause small strokes, and certainly intracranial hemorrhage from any number of causes related to the blast. And then vascular injuries are also quite common, both on the small scale with microvascular injury that causes significant inflammation from the endothelial injury, and the actual rupture and bleeding itself, whether it's intra-abdominal, intra-thoracic, or obviously from a traumatic amputated extremity. So the severity, as we mentioned, is directly proportional to the type and amount of explosive. The distance away is extremely important as a part of taking someone's history, if that's available, or at least that of a bystander. Understanding if they're in an enclosed space or not, which is not only important for having a longer exposure to that impulse wave or impulse phase, but also suffering from inhalation injury, which certainly compounds blast injury. The secondary blast injuries are, as mentioned, can be small holes, but big problems. It requires a very high index of suspicion to chase down what injuries might lie within, despite relatively small holes on the outside. Additionally, there's significant debris from the environment that's picked up. It can be dislodged, that can be lodged inside someone, which can lead to infection if it's not well debrided. And we'll talk about the debridement of these wounds shortly. Nearly any injury is possible from these penetrating injuries, and really does require both very good clinical exam, very high index of suspicion and exploration, and the liberal use of radiology when it's available and appropriate given the patient's physiology. Tertiary blast injury are when an individual is displaced from their position due to the blast wave, the blast wind, or let's say collapse of a structure that's associated with the blast. And can cause significant blunt injury or impalements on sharp objects, and certainly traumatic amputations, which are part of the hallmark of this syndrome. Quaternary blast injuries are related to heat and smoke. Burns in and of themselves obviously are very complicated injuries to manage, compounded by those who have significant either upper airway injury from heat inhalation, smoke inhalation, which can cause alveolar injury and very severe systemic inflammation, or the syndromes of systemic toxicities of compounds that are in the smoke. Obviously, we often think about carbon monoxide and cyanide poisoning, but there are certainly lots of other chemicals that were unmeasured that cause significant syndromes in humans. When all the oxygen is removed from a location quite rapidly due to a blast, particularly if it's in an enclosed space, and or if a structure collapses on someone, they're unable to ventilate, asphyxiation can be a major problem. And certainly the irritants in the smoke of these blast injuries, as we've seen from very many incidents around the world, can cause major exacerbations of chronic diseases, both in bystanders as well as those who are injured, particularly those of cardiovascular diseases and pulmonary diseases. And it's important not to forget that these injuries are very impactful for people's mental well-being as well. Coronary blast injuries are due to contamination of debris from the environment, which obviously includes bacteria and spores, a chemical exposure, radiological exposure, though rare, certainly things that we worry about with dirty bombs. Additionally, major multi-system injuries, no matter what, cause significant inflammation and immune dysregulation that can have negative effects on health and how we heal wounds, which often can be very large and complicated wounds in these patients. As such, they're very high risk of infection, which certainly lasts beyond the hours and days after injury. So a few tenets of management. There's a checklist that's published by Bevan in a nice review of the blast injuries for the civilian surgeons in 2018. And it takes a lot of experience from both humanitarian and military deployments and condenses it into basically 10 steps for how to manage these injuries, both as an individual and as a system. So we'll go through these briefly and then talk about some specific injuries. So the first is preparation. This includes training of your staff of all levels, having protocols for how to triage and manage some of these specific injuries like blast lung, and then drilling, which means there are certainly times when we might have other casualties or other conditions that we're managing, but not necessarily multiple casualties from blast injury, which often require a unique skill set and practice. So doing that ahead of time is quite important. When a multiple casualty related blast injury does occur, it's important that there's a triage system in place that is activated and different than that used for your daily emergency care. There's a coordinated resuscitation and surgical reaction that includes both a leader in each of those and then a known care plan that takes those triage patients and moves them to where they need to be. And the preparation of spaces, equipment like tourniquets, blood products, if you have access to them or can mobilize individuals to have additional blood. And certainly pacing staff both up front and then over the next days to follow as patients require multiple trips back to the operating room. So most deaths occur within 10 minutes after blast injury. And these are often in the field and due to injuries that are unsalvageable. But a large portion do die related to hemorrhage, which is why militaries and civilian surgeons who take care of these injuries somewhat more rarely have focused more on arrest of catastrophic hemorrhage before our typical ABCDEs. So this is direct pressure, packing of wounds, and if that doesn't work, certainly application of a tourniquet. And then we continue with a normal airway breathing and circulation and resuscitation as part of C after stopping catastrophic hemorrhage. So 3 is antibiotics and anti-tetanus. As we all know, these injuries can be extremely contaminated with debris and bacteria and spores and dirt and such, and they all should be treated as dirty and never closed. We'll talk about debridement specifically, the copious irrigation, but for all wounds that are greater than 6 hours old, we treat them as infected, and they get antibiotics that are appropriate for your setting, and anti-tetanus treatment, of course, for everyone. So damage control is a system of care that has evolved after significant experience by our militaries and working to control severely injured patients, often after blast injury. The goal of this resuscitation is just to maintain in-order perfusion, ideally with blood products, if not with fluids, nothing more and nothing less. Stopping bleeding early is key to being able to maintain in-order perfusion when blood supply is limited. The next is control of surgical bleeding. This includes packing, particularly of the liver, to ensure that the capsule is aligned back in its original place to minimize bleeding. Where appropriate, blood vessels can be ligated or shunted or repaired, and that's obviously beyond the scope of what we're talking about, but conceptually, controlling bleeding is key. Then controlling contamination, and this certainly means from our intestines, but also from the blast injury themselves, dead tissue, and heavily contaminated tissue with debris all needs to be removed. And then stabilizing long bone and pelvic fractures to reduce ongoing neurovascular injury and soft tissue injury and inflammation that results from that, and certainly pain, which obviously is complex to manage in these injuries at baseline, particularly with unstabilized long bone fractures. So effective and early wound excision really reduces mortality from sepsis, gas gangrene, and reduces trips to the theater, which in a stress system is really important for maintaining optimal care utilization. The International Committee for the Red Cross and Red Crescent has a wound scoring system. It's quite complex. I don't think it's necessary to use it or to know it, but I think that it's important that we take a hint from experts who care for very many blast injuries as to the importance of assessment, documentation, and following these wounds to ensure that they don't cause undue or preventable morbidity or mortality. So the principles of debridement include that the greater the damage, the more extensive the debridement needs to be. This means that all dead, dying, or grossly contaminated tissue should be excised. Metal fragments only need to be removed if they are intra-articular or within CSF or risk of damaging other structures. We don't need to go looking to remove all of them just because they exist. Oftentimes there are very, very many and can lead to prolonged times in the operating room and unnecessary bleeding. Small wounds in the skin, again, can cause significant injury from cavitation inside an extremity. So large wounds all need to be explored via extensile incisions through tissue planes that include debridement of this non-viable skin edges, certainly any injured fat, which often is laden with hemosiderin or appears bruised. All of the fascia that is non-viable, and then any muscle that certainly doesn't appear to be contractile or well vascularized. So the classic saying is remove the hamburger and leave the steak. This gets easier and easier as time goes on, but importantly, it's you do as much as you can up front to reduce the risk of infection. And then for bone fragments, there's the Tug Test, which is you take a forceps, you pull on what bone fragments you see very gently. If it comes off easily, then there's not enough soft tissue to support its viability, and it should be removed. Otherwise, it can remain until it's time for more definitive long bone stabilization. So all wounds should be decontaminated, which is extensive washing. When there's risk of chemical exposure, all clothes obviously should be removed, and that removes about that dry decontamination removes about 90% of what people are exposed to. An additional soap and water wash of the other skin areas will remove as much as possible as the rest. Certainly, all wounds require vigorous scrubbing and copious irrigations to get all the debris out of the soft tissue. And then all traumatic arthrotomies should be copiously irrigated, and any efforts to close it with viable tissue should be done when able. We mentioned the importance of stabilizing long bones. This includes splinting, external fixation, or skeletal traction, and obviously avoiding definitive fixation during the damage control process to avoid, again, prolonged times in the operating room, blood loss, hypothermia, and the effects of those in synergy. For blast injuries and crush injuries in general, particularly those with manual extremities or concomitant vascular and bony injuries, think about use of fasciotomies. And in general, if you're thinking about doing one, it probably should be done. And in these cases, they're generous incisions that decompress the full length of all compartments in the extremities, and with the goal, particularly in the lower leg, not to miss compartments, particularly the deep posterior compartment. So for 9 and 10, do all we can to minimize the care and the care utilization. So this means keeping wound care plans simple for staff and for person time, particularly when your person time is stretched. This can be aided with the use of negative pressure when able, although obviously it shouldn't be left too long, as the microairphilic environment can certainly let infections get out of control if they're not well debrided and cared for. Prepare for significant critical care phases for these patients if you're able to support that level of care, and then multiple returns to the operating theater. And then obviously the disposition depends on the context and the resources available, which obviously thinking about transfer when you're unable to provide this care and transfer is an option. If it's not, thinking about comfort-focused care rather than costly consumption of resources and person time. And then with amputees and mental health-related sequelae of these injuries, rehabilitation service becomes really important. So just a few specific injury patterns to talk about. First is blast lung. Initially, this might present as a pneumothorax during your primary survey, but can progress quite quickly over the next hours to significant hypoxemia and ultimately difficult with ventilation, in a process that's analogous to pulmonary contusions, with significant hemorrhage and edema that happen as the pressure wave pushes blood and inflammatory mediators into the alveoli, and the negative pressure waves pull air back into the alveoli, which can cause embolism, which can cause systemic effects, including as part of the syndrome of blast traumatic brain injury. It's often a clinical diagnosis in austere settings, but certainly the classic appearance of the butterfly bilateral pulmonary infiltrates can be seen on chest X-ray. The management is similar to pulmonary contusion, ARDS, with delivery of appropriate levels of oxygen and flow rates, decompressing the chest if it's required due to hemopneumothorax, and considering placing a chest tube prior to positive pressure ventilation or prolonged transports in patients with stigmata of exposure to blasts. Be very goal-directed with your fluid resuscitation and de-resuscitate when able to minimize unnecessary volume overload. Use mechanical ventilation if and when it's available and or appropriate, and lung protective ventilation if you're able to, meaning avoiding high plateau and driving pressures and providing enough expiratory pressure to prevent repeated elective trauma. In rare cases, we limit inspiratory pressures if we're concerned for alveolar pulmonary venous fistula, or certainly bronchopleural fistulas or alveolar pleural fistulas. And then occasionally there is significant bleeding from one side of the lung that can usually be seen by dense airspace disease on X-ray and evidence of hemoptysis. And for those cases, selective bronchial intubation for unilateral hemorrhage control can be done. So blast auditory injury, the inner ear is often affected, which can present as minimally as short-term tinnitus or ringing in the ears to complete long-term sensorineural hearing loss. The middle ear commonly presents as a ruptured tympanic membrane. This is a good marker for exposure to blast injury, but because it only requires about 1 to 5 pounds per square inch, it's not a good marker for being correlated with injury severity, as blast lung, for instance, requires 70 to 80 pounds per square inch. The external ear amputation is, however, an important marker for significant exposure to high pressure blast waves, and is usually associated with mortality due to traumatic brain injury. So the treatment of TM rupture includes removing debris from the canal, keeping it clean and dry, avoiding irrigations or probing or immersing the head in saline or water. Fortunately, small perforations usually heal within a month or so, but extensive perforations often require tympanoplasty in a delayed fashion, obviously by someone who's capable of doing so. During abdominal exploration, and identifying abdominal blast injuries can be quite challenging, or knowing what to do with them. Certainly perforations we're quite familiar with managing, the colon being the most common given its higher concentration of gas to solid, or to liquid, I should say. Mesenteric avulsion, obviously also being relatively straightforward to treat with regard to knowing what to do. Control bleeding, any devascularized bowel needs to be resected. However, there's lots of injuries in that gray zone where the walls of intestine, as in this photo, look quite damaged, but it's hard to know if they will turn into full thickness injuries or not. And the mesentery can be quite bruised or evolve over time. So having a low threshold to plan multiple looks in the operating room to avoid doing too much or too little operation is usually necessary. Then, as I mentioned a couple of times, blast traumatic brain injury is a bit of a unique entity. It's certainly is characterized by multiple mechanisms that generate the injury, both from the shear and stress forces that the neurons themselves take, often without much radiological evidence, even on CT scan and occasionally on MRIs. It can be very subtle. Additionally, patients can get the classic counter-coup injury, particularly if they've been thrown a distance for a tertiary blast injury. And an intracranial hemorrhage or crush of the skull also can be manifested. The spectrum of TBI signs and symptoms can be present, so keep a lookout for them and certainly think about their impacts on the patient's overall well-being, not just for the acute assessment. Care is analogous to TBI more broadly, which obviously includes avoiding secondary brain injury by keeping up the normal blood pressure, make sure they don't get hypothermic or hyperthermic, keeping their blood sugars as normal as possible, etc. Mostly it's supportive care. A few special populations and other issues, and then we'll wrap up. So people who are pregnant can have placental abruption, obviously with the interface between the muscle of the uterus and the fluid of the amniotic sac. For pregnant women who are exposed to blast injury, having continuous fetal monitoring or close serial fetal monitoring is quite important. And then screening for fetal maternal hemorrhage in the second and third trimesters also is important. In children, they have obviously anatomical and physiological considerations that make their blast injuries a bit different than adults. They have larger head injuries, larger heads, more likely to have blast-related TBI. They have narrower airways, which makes inhalation injury a little bit more of a dangerous prospect to watch and wait in children, as they can lose their airways markedly more quickly. They are more likely to have thermal losses and to get hypothermic. Certainly, the significant chest trauma is often seen without rib fractures, unlike in adults, which who often will have rib fractures associated with their pulmonary contusions. And then knowing pediatric specific vital signs, as you all know, is quite important. Additionally, communication can be challenging in infants and toddlers because of the blast auditory injury compounding on challenging communication for the pre-verbal children, as well as those who are just in the young stages of communication. And then separation from parents and families is an issue in these multiple casualty blasts, particularly, and efforts for reunification should be thought about as well. Older adults are more likely to have orthopedic injuries, have complications from the orthopedic injuries despite fixation. Certainly don't tolerate blunt chest trauma well, and that should be factored into their overall care and anticipation of complications. Access to their medications and certainly times of conflict or disaster can be very difficult. which might make their comorbidities more likely to play a role in their care. And then certainly mobility limitations with being post-amputation or as they try to recover and rehabilitate. There are lots of examples of how to improve communication barriers with people who have experienced blast injury and auditory comorbidities. Consider identifying one and having it adapted to your context so that you can use nonverbal communication aids with patients, particularly those who might have visual and auditory impairments, which are not an uncommon combination. And then lastly, the psychological well-being and stress of both patients and staff is really important to acknowledge. The acute stress symptom cluster, 5 domains of intrusive thoughts or involuntary or distressing memories and dreams, and feeling dissociated, slowing of time or separate from oneself or one's actions, having a negative mood, avoiding whether it's people or situations, or even discussion of topics, and then arousal, of being very vigilant or having intensified startle responses. All signs of acute stress symptoms that certainly can be treated and by teams that create a sense of safety, even if it's only emotional and not necessarily physical safety for them and their families, and a sense of community. There's guidance for how to address potential exposure from human remains being blasted onto or into another individual. Hepatitis B, C, and HIV, and I'll include it here, but it can be found at the CDC website as well. So as we close up, these injuries are often add stress on very stress symptoms, particularly if they have multiple or many casualties, which generates expanding nurse ratios when you need closer nursing for more severe injuries at the same time. The extensive and frequent wound cares, particularly for perineal injuries, where the wounds are often soiled, does require significant care. Anticipating critical injury and illness from blast lung, need for blood requirements, higher rates of sepsis. The multidimensional injuries which really challenge us as surgeons to provide high quality care with competing priorities. And then certainly the surgical anesthesia resource utilization that often stresses all of us. Some approaches that have been offered to force multiply, particularly in the military settings, have been early adherence to these key principles of blast injury that we've gone through to really reduce care utilization acutely and over the long term, to protocolize serial exams to avoid missed injuries or reduce delays in diagnosis. Consider tracheostomy for patients who require many aesthetics or have complex wound cares that get exposure to high doses of opioid medications or anxiolytics that might lose their airway otherwise or require more presence of an anesthesiologist who may not exist. The use of negative pressure wound systems to minimize the frequency of dressing changes, and then obviously leveraging family for care tasks. So as you're taking care of these injuries, really think about the physics, take as good of history as you can from bystanders to really understand the exposures that these individuals received. Anticipate the injuries in accordance with the blast category framework. Develop protocols to really ensure efficient management of these patients within your own systems. And then think about ways you can force multiply in your setting to manage these complex patients when your system is stressed even further. So happy to take any questions.
Okay, thank you so much, Dr. Stewart, for that. I have already a whole page of questions. Unfortunately, we're really running short on time, so we're going to move over to Dr. Shaw if you want to share your slides. And she's going to give just a very high yield, high impact guide to point of care ultrasound for the trauma setting. And then at the end, we're going to try to, get through as many questions as we possibly can. So we have to keep time in mind. But thank you both. And Dr. Shaw, you can go on and get started.
Thank you. Can you guys hear me? Give me a thumbs up. Okay, great. Thanks so much for having me. This will be a super high level overview. We're going to focus on EFAST, which is the extended focused assessment with sonography and trauma. Actually, as Dr. Stewart was talking, I was sitting here thinking about and adding to the last slide, which is all the uses of ultrasound in trauma, and there's quite a few, but from looking for TBI to looking for a blast lung. And so hopefully you'll find this useful as an adjunct. So the purpose of the EFAST is to rapidly identify free fluid, which is usually blood in the setting of trauma, in the peritoneal space, around the heart, or in either of the pleural spaces, and then use this information to guide your clinical decision-making. It's usually performed directly after the ABCs of the primary survey as part of the C, looking for circulatory challenges or hemorrhage. And it is highly sensitive and specific for recognizing blood in the peritoneum. Studies show it's between 60% and 95% sensitive for looking for blood. Obviously, more bleeding in the peritoneum is easier to see on ultrasound. For diagnosing cardiac injuries from penetrating trauma, because we'll see bleeding in the pericardial sac, and also for identifying hemo or pneumothorax. It is indicated in hemodynamically unstable trauma patients to help guide your operative plan of what to open first. Is there blood in the abdomen causing hypotension, or blood in the chest causing hypotension? It's also useful in hemodynamically stable patients. It takes about 25 to 30 fast scans to become clinically competent and feel confident in your findings. So even if there is time to practice in stable patients, then that's useful for gaining your own skills. But also in stable patients in a mass casualty setting, it can help give a clue as to who will become unstable. If you identify small bleeding in some cavity in the chest or in the belly, you can identify that before the hypotension and help to gauge and triage those patients, or transfer them appropriately, or guide further workup. So here is a super simple algorithm of how you would use this information. If you have access to a CAT scan and you have a stable patient, obviously that patient can wait. If your CAT scan is limited or you don't have access, you can use ultrasound for a temporizing piece of information. In an unstable patient, if you find frank hemoperitoneum after a trauma, you know you're going to the operating room. If the patient has a pneumothorax or a large hemothorax, you know you may put in a chest tube and help relieve any sort of hypotension that way. If you have a penetrating thoraco-abdominal trauma that may have injured the heart, your first look is going to be at the pericardium. And if you see blood around the heart, then you know that that is the cause of the tamponade and the hypotension. If you have a normal ultrasound, you can begin the search for other causes of hypotension. If they have neurogenic shock, if they have cardiogenic shock, if they're elderly, if they have a large scalp laceration, they're bleeding into their thigh from a long bone fracture, you can also consider doing a serial fast, waiting 20, 30 minutes and looking again to see if there's more bleeding, and you'd be able to see. If you're fairly convinced that the blood is in the belly and you just can't see it on ultrasound, definitely consider a DPA, diagnostic peritoneal aspirate, for more information. There are some types of bleeding, especially if it's clustered in the mesentery, that is hard to see on ultrasound. The FAST exam for the abdomen has three spaces to look in: the hepatorenal space, also known as Morrison's pouch, the splenorenal space, or the bladder and the uterus, in a subxiphoid view of the heart to look for blood around the heart. And when we're in either of the two sides of the body, hepatorenal or splenorenal, we slide the probe superiorly to look for hemothorax as part of the extended fast. So The probe for the first space, and you don't have to go in this order, looking for blood in the abdomen. If somebody appears really injured on the left, or they were laying in a left-sided position, I'll look around the spleen first. Once the fast is positive and you see blood in the abdomen, you don't have to continue the rest of the fast. So I'll put it in this order, but go wherever you can to look for fluid. But you need to try to complete the fast if it's negative so that you see in all the spaces. So in the hepatorenal exam, you want to fully interrogate the entire area. And that means taking your probe and placing it along the lower two ribs, usually in the mid-axillary line to start. And then you aim the probe, kind of angle it like a flashlight where you want to see. And you're going to aim it a little bit posteriorly. And what you'll see is a view of the liver, and ideally a view of the kidney. And you're looking at this Morrison's pouch, which is the space between them. You'll also want to slide this probe a little bit towards the patient's feet to look to see the inferior area of both the liver tip and the inferior pole of that kidney. The most common thing that happens is people put the probe down and they just see liver and a whole bunch of bowel gas. And all that means is you just have to take your probe and then aim it a little towards the patient's back, and you'll see the kidney, because remember, that's retroperitoneal, as you all well know. So here's an example. You want the probe marker. This is a sagittal plane. So every probe has a marker, and you want that marker pointed towards the patient's head or their right side. That will help you orient, and if you always do it the same way every time. So the marker is towards the patient's head here. This probe is aimed pretty much straight on, but he may have to raise his hand and then aim towards the patient's back a little bit. And we're looking between the liver and the kidney. And so we're looking here. And here's an example of what an abnormal fast or a positive fast would look like. Here's our liver, here's our kidney. This little strip is little perinephric fat and fascia surrounding the kidney, but this dark strip here pointed to by the arrow, this is blood. So blood, urine, ascites, they all appear dark black or hypoechoic on ultrasound. The ultrasound can't tell me whether that dark stripe is blood, ascites from someone's cirrhosis, or just urine because they blasted their bladder and it exploded and now there's uroperitoneum. But common things being common in a patient with blunt trauma and hypotension, if you see this is probably blood. And if you were concerned and you weren't sure, you could always aspirate. But this is an example of a positive fast. So we could stop here. If this was our first view, we would know there's blood in the belly. There is data that the size of this stripe correlates to the amount of bleeding. So a thin little sliver might be less blood, or a big stripe might suggest more blood. This is with a patient, remember, laying flat because they're a trauma patient and their spine is immobilized. So the blood you would expect is pooling in the right and left upper quadrants. Similarly, on the left side, we're going to look between the spleen and the kidney. In this view, you're going to have to place your probe a little bit more posterior and a little bit higher. But again, mid to posterior axillary line, aiming towards the patient's back and looking at the space between, this bright white is the diaphragm. It's a very dense structure, so it appears bright white. And then this gray tissue here is the spleen. So we're going to look between the diaphragm and the spleen. We're going to look between this kidney and the spleen right here to look for any free fluid or blood. The reason why we have to go fairly posteriorly, obviously, is that the stomach is usually full of gas bubbles and that can obscure your view. So your hand with the probe will have to be very, very posterior, almost touching the gurney or stretcher. So you'll be back here looking between the spleen and the kidney. And this is what you'll see in a patient with no bleeding. A bright white diaphragm, obviously there's a line drawn here, but it usually appears as this kind of bright white line. Remember, this marker, this little dot, correlates to the marker on the probe. That's towards the patient's head. So anything on this side of this diaphragm is the chest. So this is the costophrenic recess where blood in the chest might hide. But anything on this side, on the right side, when the marker is pointed towards the patient's head, will be in the abdomen. So here we see the spleen. We don't see any dark fluid separating that nice white diaphragm from the gray texture of the spleen. And we don't see any blood separating the spleen from the normal appearing kidney. Here's an example of a positive FAST on this side. Here's the diaphragm, and it's outlined really well because we are separating the diaphragm from this spleen, which is the gray tissue, by this dark stripe. This is an example of bleeding, so hemoperitoneum. You don't see a ton of blood in here. This could just be fat, but it could also be clotted blood. Sometimes that appears gray. Occasionally, you won't see any bleeding between the liver and between the spleen and the kidney, or between the spleen and the diaphragm. But if you look at the tip of that spleen or the tip of the liver, you'll see this little, we call it like the tiger claw sign. So a little dark kind of triangle just at the tip, and that's kind of where the bleeding will start often. The next place to look, again, this is a super fast overview, is in the pelvis to look for blood surrounding the bladder. Now, here's an example of, you got to place the probe very low and then aim into the pelvis. Here's an example of a normal bladder. Remember, the bladder is filled with urine. It also appears dark, but you can tell that it's the bladder because it's kind of this roundish structure. All the fluid is within these walls of the bladder. And then we're going to look for free fluid in the abdomen deep to the bladder around either the uterus or the prostate. So here's an example. Here's our bladder. Here's free fluid in the pelvis. In women of childbearing age, you may see some trace free fluid in the pelvis. Usually it doesn't take up more than approximately a third of the volume of the uterus. So tiny, tiny bits. And if that's the only place you see it, that may just be physiologic fluid. You should not see that in a male patient, and you should not see large volume. Like this would probably be too much fluid to be called physiologic. Here's another example, bladder, ligaments, suspending uterus, and all this back here is fluid outside the bladder. So blood. So here's a live video. Here's our liver. Here is some free fluid. And you see this little stripe. It's hard to see. This is a lot of bowel gas. We don't see the kidney very well in this image, but we're fanning our probe back and forth to look for fluid. And here's an example looking in the pelvis. This is just all bowel and maybe some clotted blood, very difficult to see. They're going to aim their probe deeper into the patient's pelvis, and then you'll see a bladder right up here. There we go. Here's our bladder. Here's the free fluid behind the bladder. So if you put the probe down and all you see is bowels, because they're full of gas, it looks gray, remember to kind of aim your probe a little bit. And I'm going to talk super quickly about the subxiphoid view. If you have a penetrating thoracoabdominal wound and you're worried about tamponade as a cause of the patient's hypotension, a quick view of the heart, just looking for fluid around the heart within the pericardium can help. In this view, we're coming, the probe is placed just under the xiphoid, very flat on the patient's upper abdomen, aiming towards the heart into the chest. Here we see a little bit of liver, and then the heart. The bright white kind of sac surrounding the heart is the pericardium. And then here's the right ventricle, right atrium, left ventricle. You would look for fluid either here between this free wall of the right ventricle and the pericardium, or deep to here, depending on the patient's position and gravity. So here's an example of what that looks like. Here's liver, here's diaphragm, here's free fluid around the heart. You know, in a TB patient or a cancer patient, this might just be slow growing free fluid, but in the setting of trauma, you'd have to worry that this patient had a penetrating cardiac injury and that this was blood. And even a small stripe, if it's rapidly accumulating, can cause hypotension, and this patient would need a repair. And here we see a little bit of free fluid outside of the left ventricle. So here's an example of a large amount of free fluid outside the heart. The heart is kind of swinging back and forth. The bright white stripe down here is the pericardium. This is the blood around the heart. Here is the free wall of the left ventricle. And what we notice here about the RV, the right ventricle, this free wall is being collapsed under the pressure of this rapidly growing pericardial fluid, which is probably blood. We could slow this down. And if we see that this is diastolic collapse, that's the ultrasound finding of tamponade. You'll often see this finding before frank hypotension. So it's your clue that your patient is about to get sicker because this fluid is causing a significant amount of pressure that's not allowing the right ventricle to fill. The E part of the extended fast just means that we're gonna slide our probe a little bit superiorly when we're in the right and left upper quadrants to look for blood above the diaphragm. That will suggest hemothorax. And then we're gonna switch our probe around to the anterior part of the chest in a supine patient to look for pneumothorax. I popped this in here while Dr. Stewart was talking because we were talking about blast injuries, just to show you a quick video of what that looks like. If you place the probe on the chest, any alveolar process, whether it's pulmonary contusion, blast lung, miliary TB actually, will look like this. Normally, what we see is, here's the pleural line, and it looks almost like flashlights looking down in water. Usually you might see one B line, which is this little white line that extends all the way down in a healthy patient. If you see so many white lines extending down, these are called B lines, from this pleural line, that suggests that there's something junky in the alveoli. Maybe this is a blast injury. Again, it's going to be treated pretty similarly as ARDS or pulmonary contusion, just supportively. But if you wanted to take a quick look, or you noticed this when you were doing your trauma evaluation, that's what that would look like. And that would be with the probe in the anterior chest on either side. Okay. So again, the probe marker, this little guy, or on some probes, it's just a little dot, is going to be up towards the chest. In a pneumothorax, if it's small, in a supine patient, you might see it only here. You might look for the pneumo here. In a large pneumothorax, you might see what's called lack of lung sliding, our clue, in many areas. So you'll want to look in a few different rib spaces. When compared with a chest X-ray, ultrasound is more sensitive for pneumothorax, especially in a supine patient, because those are difficult to see on portable chest X-ray. And what we're looking for in normal lung, we put the probe between the rib spaces. Here's a rib. You can't really see through a rib, so it looks all dark behind it. This white line just below this bright white rib looks like it's sliding or shimmering. That's normal. That's the visceral and parietal pleura up against each other, moving. That means there's no pneumothorax. In a pneumothorax, this bright white line, which is the pleural line, shows no sliding. You can see that the chest wall is moving a little bit, but you don't see that normal kind of shimmering sliding. You also don't see any occasional B lines coming down. Normally you'd have one or two B lines, remember. And so here's our rib. It looks kind of bright white. Here's a rib. And so this white line that's just below the ribs, before the rib shadow, that's our pleural line where we're going to look for sliding. So sliding's normal. Lack of sliding could suggest pneumothorax. You'll see lack of sliding in patients with horrible COPD, with really scarred lungs from prior TB. And we don't know what a post-COVID world looks like when lots of people have had bad pulmonary COVID. So all this data showing that ultrasound is fantastic at pneumothorax came from places where TB is not endemic and pre-COVID. So this will be a new feature of what we're learning about our new world. Quick showing you what hemothorax looks like. Remember, here's our diaphragm. Our probe is in the right or left upper quadrant here and here. And then fluid above the diaphragm towards the head, this is a hemothorax. Again, here, large hemothorax, diaphragm, solid organ, spleen or liver, I can't quite tell. So to summarize, serial exams can help your sensitivity. If a patient's hypotensive and you don't quite see blood, come back in 15 minutes. If you are able, if they don't have a TBI, you can put their head a little bit in the head down position, and then blood might run up the paracolic gutters into the right or left upper quadrant. You might be able to see it more easily. Remember to do all the views if you are looking for blood and don't find it. And then consider the whole clinical picture. Remember, clotted blood might not look as dark, it might look gray. I have seen a patient with a big pool of blood in their mesentery that didn't ever get to the right or left upper quadrant. I didn't find it, but the DPA was positive and they went to the OR. Retroperitoneal bleeds, we're not really going to see very well, but again, they're probably not going to bleed to death from that. And then hollow viscous injuries, diaphragmatic injuries, ultrasound is not going to be able to help you. So remember the limitations of the FAST. And then in looking at lung sliding, as I mentioned, you might have some scenarios where you don't have lung sliding, but you don't have a pneumothorax. But for the most part, if you suspect it and you don't see lung sliding, you're good to go with the chest tube. I'm going to skip this slide just for timing because I know we're tight. And then there's a myriad of other uses in mass casualty for ultrasound for helping to triage. Other uses specifically in trauma that I wanted to mention that were helpful for me when I went to the earthquake in Haiti in 2010, as we had hundreds of patients and I had to, as an emergency physician, triage them all for the operating room. And so the use of ultrasound for nerve blocks, especially for bad injuries of the lower extremity, you can avoid needing an anesthesiologist, or you can avoid a lot of pain if you can do a femoral block, especially with a long-acting agent, and numb the whole leg. Vascular access is sometimes a problem when patients are severely dehydrated, so ultrasound can help. If you don't have an X-ray, but you are intubating somebody, you can quickly look at the trachea and surrounding tissues to look for ET tube placement. And you can look at both lungs to make sure they're sliding appropriately when you're ventilating. That's kind of your quick view of, did I put the tube in the right place? Foreign body location, as Dr. Stewart mentioned, you're not needing to really remove these if they're just in the soft tissue, but if you wanted to see if they were damaging structures, you could follow and look for them. Post-trauma, we found a lot of DVTs in our post-op patients in Haiti. Obviously, patients laying around with their legs immobilized, looking for DVTs is helpful. And then post-operative pneumonia, ultrasound's pretty great for pneumonia. And then during the trauma evaluation, sorry, I skipped this one, you'll want to look, clinically, you'll look for signs of elevated ICP, but you can also look at the eyes, actually with the closed lid and just the ultrasound probe on the eye for papilledema, which might be helpful to give you a clue that there's a traumatic brain injury. Long bone fractures, you can identify just by running the probe down the long bone and just looking to see if you see a break. And then that can help you with your reduction too, to stop your bleeding. We do this a lot in kids just because we don't want to be x-raying them. We use it almost like fluoroscopy. Again, I mentioned looking for B lines in the lung for evidence of contusion, hemorrhage, or alveolar processes if you don't have an x-ray. And then preoperatively, I liked it for volume assessment, just grossly looking to see if somebody's super dry and needs a lot of volume or just medium dry. And then pregnancy in female patients. When you're looking near the bladder, you may find that the patient is pregnant, especially if they can't tell you. And then in elderly patients, a gross idea of what their left ventricle is doing in terms of squeezing when you're looking at the heart can be helpful looking at their operative risk. So, and Solidarity, thank you so much. I know this was really tight on time and super fast, but my email is below if you wanted me to email you any videos for learning and going deeper with any of these kind of concepts that I mentioned. Ultrasound is a whole new world for diagnostic imaging, especially on the go or in the field or in mass casualty. So please feel free to reach out as you need.
Thank you both so much. I know we are already over time and we have about a page and a half of questions. So we're going to have to go really, really quickly. very rapid fire. I'm going to show the questions onto the screen, but Dr. Hoffman, if you wanted to give any comments on either of the talks, you can do that while I am pulling up my screen.
Sure. So the resource limitation, depending on how you guys are practicing and your skill set, may limit what your abilities are to do with blast injuries. And so remember, it's going to be a triage situation way up front. And if you have blast injuries with 20-ish people and you have someone that has a limb blown off, by definition, they are probably going to have a lethal lung injury to start with. If you don't have advanced capabilities for ventilation in an ICU, they're even difficult in the best modern care. And so that's something to be aware of. For patients that are okay and you triage away, you just have to let them know that, number one, if they get short of breath, to come back. Number two, they're at risk for perforated bowel injury in a delayed fashion. Right, so let these people know that even if they walk away, that if they develop new abdominal pain, new breathing issues, to come back. Right, the TBI thing, there's nothing to do, unfortunately. And short of having a neurosurgeon, I would let them know that any neurologic symptoms are probably just going to be there. But that's more of a triage thing. I'm not entirely sure your resource limitations in either of the locations that this is oriented towards.
All right, thank you so much. So with these questions, we're going to try to cover as many as possible. We really need to get through them in as short a period of time as possible. So if you could just answer quickly. So in terms of field management for blast and ballistic injuries, can you comment on the modifications? I believe you mentioned this in your talk, but modifications to initial ABCs. If they can't do damage control within 6 hours, are there any interventions they can do? And who is generally managing these acute blast injuries in the pre-hospital setting? And then if you could just comment on these things in a very resource limited setting, as some people were commenting that they are in a rural war zone with few supplies, long transport time, and no antibiotics.
Yeah, so in the field, the ABCDEs are pretty similar, except for doing all you can to control hemorrhage up front, particularly when you lack access to blood products. So otherwise, stick to the fundamentals and frameworks that you're comfortable with and you use daily, just to make sure that you don't miss anything. But stopping bleeding is so important early and upfront. And what can we do for field and hospital damage control for blast? For field, again, outside of controlling bleeding and very simple airway management chest decompression, if you think there's a pneumothorax, there's not much you can do. Even long transport with spine immobilization in patients who can't be closely monitored is hotly debated. So not much additional in the pre-hospital setting. If you can't get to them within 6 hours, you get to folks who, when you're able and how you're able. As Dr. Hoffman mentioned, it really is a context-specific triage guideline. Execution and planning is really what's important. So having a clear understanding of what your capabilities are, particularly as you receive influxes of patients, and anticipating what that might look like to help guide your triage decisions up front. And then the last question, I'm not quite sure, the usual providers to manage acute stress due to blast injuries in the pre-hospital setting. If you mean acute stress symptoms as in early PTSD, certainly there are health workers in the community that can be trained and have been trained, and Cambodia has a prime example of this to help manage acute stress symptoms of patients and families affected by landmines. And that's usually lay individuals with just careful training on how to support patients and families.
All right. For hemostasis, how can you stop the bleeding with bandages in the field? Should you attempt to get hemostasis first, or repair the bone first, and then I'll combine that, I guess, with the next. When do you amputate? Is that immediate or a delayed decision based on healing?
Yeah, keep hemostasis as a really primary function, particularly with limited blood products. People that don't have access to blood upfront or over time, particularly as they go back and forth to the operating room, lots of wound care, potentially malnutrition, etc. Keeping all those red cells are really important. So I would always try to do that first. Being really consistent with your stopping the bleed. Certainly, if you have enough individuals holding direct pressure and packing wounds real tight and adding pressure dressings can be helpful. But if you are limited in staff and need to have a force multiplier with a tourniquet for catastrophic hemorrhage risk, as well as to be a force multiplier for an individual, taking care of a single person is certainly added. For those junctional hemorrhages of the groins, the axilla and neck, it's obviously very difficult, and these patients often have injuries that can't be survived in rural complex settings. And the amputation decision is a really complex discussion that's probably beyond a quick answer to this question, but upfront, just thinking damage control, stopping bleeding, getting all the dead tissue and heavily contaminated tissue off of the extremity, maintaining length as you're able, and then as you go to reconstruct, thinking about what is and what isn't a useful limb or a level of amputation. But again, that's a more complex discussion that we can do over email if need be.
Okay. In terms of chemical weapons, we're probably going to have a separate entire session on that, so we won't belabor that very much. But other injury type specific questions, and I know Dr. Hoffman is familiar with this as well, if you have any comments. Do you have any modifications on wound management based on the kind of explosive device versus missile or air bomb? And then if you have a rocket hit a building, what's going to kill people? Is that the building or the blast? What do you look for in such a war type event? And do you get blast injury from high velocity gun or mortar hit?
Yes, you definitely get blast effects from high velocity guns. There's a cavitation effect that occurs separate from the actual trajectory. Supposedly in the declarations of where people are supposed to be using steel metal jackets, but all bets have been thrown out recently. How do you prevent fat thrombosis? You can't, unfortunately. I see that one there. Going back to your other ones, fixing a bone is not going to stop bleeding specifically, but stabilizing the actual bone fracture is. So the best thing to do with a broken bone is to stretch it out to length, stabilize it by any means necessary. So basically homemade splints, and then wrapping that leg or arm to get it stabilized. Arms would just be a sling. Most legs will be some variation of long bone stabilization via boards, basically anything you can have that can stabilize it. And then going to someone asked about specific management of injuries, and you have to recognize what your field of play is in terms of whose bombs are these and whose mines are these and how are they working. So in the Colombian Civil War conflict, they were covering their landmines with human feces, which resulted in a lot of E. coli infections. And if that's not the case, then it's basically whatever grows in your native environment is what's going to be on your mines and projectiles.
All right, and I know that Dr. Shah has commented in the chat as well that tetanus vaccine and immunoglobulin needs to be kept cold chain throughout its life to be effective. Any other comments on tetanus or fat thrombosis? Anyone?
Fat thrombosis is just supportive care. Basically, the presentation will be a patient that is doing somewhat okay, all of a sudden develops shortness of breath, and on their, for example, on their ultrasound, They won't necessarily have a pneumothorax or hemothorax. You may or may not, as it's occurring, if you're lucky enough to see it as it's occurring, you will see the emboli going through the heart if you were able to do ultrasound at that time. But usually it's a delayed presentation. It can it's not that common. Even in major trauma centers, we see it maybe once every 3 to 5 years.
All right. How frequently is serial debridement needed? And then a very different question, in a situation requiring amputation of a combatant's limb, what kind of consent is needed, verbal or written? And I just put on their religious considerations because I know that particularly in Asia, amputation removal of body parts is a very significant issue for particularly for Hmong and other populations. So I don't know if anyone has comments on those things.
You still need consent, but if the patient is obtunded and cannot give consent, then the physician should ethically do what is necessary to save the patient's life unless they have pre-existing wishes. We ran into this a lot in Haiti. Patients said, I'd rather just see how it goes and I might die because living without a limb in this rubble after the earthquake is going to be a really tricky situation, and I don't want to do it. And so we had to work with, and the local physicians were like, yeah, we have patients refuse amputation all the time. And so we had to often work with these patients and round on them every day, and their surgeries were often delayed, but to get them to come around, because if they're awake and competent, they get to consent or not consent. And we had a lot of issues with foreign physicians coming in and wanting to just be like, well, they don't know what's good for them, and doing a surgery which without consent, which is ethically very concerning, obviously.
All right, just some POCUS questions, which I know Dr. Shah had answered in the chat, but also just I'll give you a chance to answer them verbally because the chat won't be reflected in the recording. So, yes, how much force is needed? How relevant is POCUS in soft tissue injuries and fractures? And what's the minimum amount of fluid you can see on EFAST?
Sure. Very little force. Just think of applying a small amount of gel to the probe, and you can use shampoo, you can use water, but some sort of liquid is needed to make contact between the probe and the skin. And then don't push. You really rarely have to push, and it's painful. And so just a bit of contact. And you can see anywhere between 20 and 30 mLs in the chest, so very little of fluid or blood. And in the abdomen, it's debated, with 100 mLs, 200 mLs, 300 mLs, but you're not, it's fairly sensitive for seeing kind of small amounts of bleeding, actually. And then soft tissue injuries and fractures, it is very relevant for looking for fractures and then guiding reduction, looking for muscle tears, tendon tears. But again, big injuries, you would be probably focusing on kind of other stuff. You can use POCUS to identify elevated ICP. This is often a clinical diagnosis, but what you will want to do is use gel on a closed eyelid, look with the ultrasound probe at the deep part of the retina and look for papilledema. You could Google image what papilledema looks like. The eye is very easy to ultrasound. Papilledema both sides, elevated ICP. Papilledema one side, it's an eye process and not a brain process. And then you can use one probe for all the EFAST. You can use a curved probe. You can use a phased array probe. You probably can't use a linear probe. It's just too shallow looking. It makes superficial structures look good, but curve a linear probe for everything is great. Just change your depth. And all the initial studies were with a curved probe for looking for pneumothorax. You just have to change the depth and you'll get used to it. But it is easier and prettier with a linear probe to see a pneumothorax. Features in an ultrasound machine, you want it to stand up to heat and humidity and being bashed around because it will. And then you want it to be pretty lightweight. You want it to have long battery length. So you want to ask about how long does the battery last while I'm scanning. And then, and you want it to be portable. Now they have a bunch of handheld machines that you can plug into an iPad. The cost is around a few $1,000s. You can plug it into a phone. So they're getting cheaper and more portable with pretty good image quality. I would also suggest that you want the capacity to send your images easily to get help. I'm not a radiologist. I send my images all the time. I'm not a cardiologist. I send my ultrasound videos of the heart all the time. So you have this online network and connection even through this group to be able to send images. So a probe that will be able to do that would be great. Point of care ultrasound is meant for clinicians. It's not meant for sonographers or radiologists. It's just a different model. So I only usually send my images to a radiologist for help if I am having trouble interpreting them, but they're not meant to be kind of formal, long scans. They're meant to be kind of quick, answering very specific questions for ultrasounds. There's a question in there about whether we send our ultrasounds formally for overreading, and we don't. B-lines, 1 or 2 B-lines per rib space can be seen in normal lung. And if you have more than 1 or 2 B-lines, you have 8 B-lines between 2 rib spaces, that's abnormal. So occasional B-lines are fine, 1 or 2, but between a rib space, if you have more than 2, that's considered abnormal. And an alveolar process like edema or hemorrhage or blast injury. I never perform contrast enhanced EFAST. I might be behind the times, but we're not really doing that. And then is EFAST sensitive in pregnant patients in the 3rd trimester? Yes, and we use ultrasound a lot in pregnant patients as an alternative to CT, to looking for fluid. Obviously, in the 3rd trimester, you're looking at kind of fetal well-being, so fetal heart rate, but you can still see between mom's liver and kidney. You can still see between mom's spleen and kidney. The pelvis view is really hard because everything is compressed.
All right. Well, thank you very much to everyone for hanging in there. I know that that was a long session with a lot of content. It will be recorded and put online so that you can always reference it if you'd like. And then also it will be translated into Ukrainian for our European colleagues. So thank you all. Thanks to the speakers and to Dr. Hoffman, the discussant. And we will see you at our next session.